Welcome to SimplyRN. This video is for educational purposes only and not indicated for clinical use. Today's topic is spinal cord injury or SCI. SCI refers to injury to any part of the spinal cord which starts from the bottom of the brainstem and ends in the lumbar region of the spine. Spinal cord transmits sensory and motor signals between the brain and the rest of the body. It also regulates autonomic functions such as breathing, circulation, digestion, urinary elimination, and sexual function. Injury to the spinal cord results in loss of function below the level of injury. Spinal cord injury can also be complete or incomplete. Complete SCI means there is complete loss of motor and sensory function, in which the patient cannot move or feel anything below the level of injury. Incomplete SCI means there is some preserved function below the level of injury. It can be sensory incomplete, in which sensory function is preserved below the injury, but not motor function. Or it could be motor incomplete, in which motor function is preserved below the injury, but not sensory function. Signs and symptoms. The higher the spinal cord injury, the higher the risk of having complications. For example, SCI above C5, which is the fifth cervical vertebra, puts patients at high risk for respiratory compromise because it affects the respiratory muscles and also phrenic nerve, which is the nerve that controls the diaphragm and aids in breathing. Intubation is often required to maintain respiratory function. Injury to the cervical region leads to tetraplegia or quadriplegia, which is paralysis of all four extremities, and paraplegia refers to paralysis of the lower extremities, which usually occur with SCI below T1. There are also neurological deficits, as mentioned before, which include motor weakness or loss of motor function, altered sensation or sensory loss, and abnormal reflexes. There will also be problems with bowel and bladder elimination. For example, SCI at T12 or higher affects the upper motor neuron and leads to a spastic or reflex bladder. This means a reflex is triggered when the bladder is full and causes the bladder muscles to contract to release urine. Normally, that signal gets sent to the brain and our body can stop the muscle contraction and hold the urine in. However, with injury at T12 or above, that signal cannot travel to the brain and results in urinary incontinence. If the SCI occurs below T12, lower motor neurons are affected, and bladder muscles do not contract to release urine when the bladder is full, and as a result, urinary retention occurs. That is referred to as a neurogenic or flaccid bladder. So remember, T12 or higher results in spastic bladder, and below T12 results in neurogenic bladder. For bowel problems, there could be constipation versus bowel incontinence. Even though patients with SCI may have less sensation, they can still suffer from neurogenic pain, which is associated with intense burning and stinging. Or they could have pain from spasticity or muscle tightness. There also could be sexual dysfunction. Besides acute respiratory failure, other complications like neurogenic shock and autonomic dysreflexia can occur. I have a separate video on autonomic dysreflexia if you want to learn more, but in short, autonomic dysreflexia occurs with SCI at or above T6. And it is triggered by a stimulus below the level of injury, usually a full bladder, and it results in dangerously high blood pressure and high risk for hemorrhagic stroke. Neurogenic shock occurs in the initial stages of SCI due to swelling around the injury site, which increases pressure and disrupts blood flow. Because of that, there is a dramatic decrease in blood pressure due to vasodilation and also bradycardia. The body lost the ability to increase heart rate and vasoconstriction due to the injury. Neurogenic shock occurs when the injury is above T6. You may have heard of spinal shock, which is different from neurogenic shock. Spinal shock is the loss of all function below the injury, while neurogenic shock is a circulation issue. Medical treatments include decompressive laminectomy. Remember, ectomy means surgical removal, and laminectomy means surgical removal of the lamina, which is the bones that cover the spinal canal and protects the spinal cord. In SCI, part or all of the lamina is removed surgically to relieve pressure on the spinal cord. There is also skeletal traction, in which a surgical pin or wire is inserted into the bone of the spine and connected to a device that applies a traction or stretching force to realign the spine. The key nursing priority for patients on traction devices is infection prevention. Assess pin sites for infection and no showers, but sponge bath is okay. Pharmacological interventions for SCI include steroids to decrease inflammation and reduce further damage to the spinal cord, and muscle relaxants such as baclofen are for spastic pain. Let's end this video with nursing interventions. With a new SCI, the number one priority is airway maintenance, followed by spinal cord protection. Assess for needs for early intubation such as spinal cord injury at C5 and above, or patients who are totally paralyzed. Continuously monitor O2 saturation and monitor for altered mental status, breathing changes, and increased work of breathing. The next priority is immobilization and maintaining spinal alignment until the patient is stable. Immobilize the spine with cervical collar and backboard to prevent complicating existing injuries. Log roll the patient to avoid bending or twisting the spine if needed. Monitor for bradycardia and hypotension, which are signs for neurogenic shock as previously discussed. Supportive treatment such as IV fluids, vasopressors, and atropine are given to increase heart rate and blood pressure. Orthostatic hypotension is pretty common in these patients because they struggle with venous return due to a lack of muscular function and vasoconstriction. Bladder management includes scheduled voiding, intermittent catheterization, or insertion of indwelling urinary catheter for retention. It is very important to check abdominal distension because remember, a full bladder is the number one cause for autonomic dysreflexia. Bowel management includes adequate fluid and fiber intake, use of stool softener, and digital stimulation to prevent constipation. But be careful when performing digital stimulation because it can trigger the vasovagal response and cause sudden drop of blood pressure and heart rate, and results in syncope. Other nursing interventions include nutritional support with tube feed if swallowing is affected, pressure ulcer and skin breakdown prevention to do immobilization and incontinence, perform range of motion to prevent contracture, prevent DVT by placing sequential compression devices, compression stocks, and administration of anticoagulants. Intense rehabilitation therapy with physical, occupational, and speech therapy is often required once SCI is stabilized. Here is a summary of the level of spinal cord injury and their complications. Take a screenshot of this and remember them for nursing exams. If you want to drill this into your memory, make sure to check out my next video in which I will be doing a study buddy review on this topic. See you next time.